So having the prerogative of the moderator here, I'd like to start off with just some questions, and I think I'll start off with you, Monica. Is you started off in this network, this Deep South network, which, as you had stated, had been going on for 15 years by the time we really started to do any sort of work with diet and exercise. And so I'd like to kind of get a sense from you as far as, are there, obviously it takes a while to establish trust, and oftentimes people do not have the luxury of all that time. So maybe to talk about the benchmarks that you would try to observe in a community that shows that it's ripe in order to really roll out an intervention and what you'd need to do.
Sure. So the Deep South Network, as I was describing it, I guess probably by the time we were doing this most recent trial was probably about 10 years involved. So the first 5 years was really about building up the trust, building up the network, doing the initial training of the volunteers. So about 800 or so individuals across 20 to 22 counties were trained and were ripe, and it included forming relationships with state and local community-based organizations and so forth. And they actually started some intervention programs around year 6 involved in that, but they were not the randomized trials. That started about 5 years ago. So I think having spent the most of my career doing community-based participatory research, I think you can never have enough time to do that formative work. And like many of the other presenters before, it all depends on the particular community in terms of how long you need. One of the things that I know I benefited from is from coming into an existing network where I was essentially introduced to the network that existed. I still had some lead time for people to trust me as an individual, but I was able to leverage the fact that there were other investigators that I collaborated with that had some involvement with these communities to begin with. So that would be the first thing, is if you're thinking about these kinds of programs, that you would try to partner with someone who's already had some established work if you don't have as much lead time, and that can be very helpful. But recognizing, as the presenters earlier today and talking about the social cultural issues, is that you need that time to kind of understand your own bias, to be able to understand and listen to what the community is talking about. Also have, as Fabio was talking about, that flexibility. So realizing that what you might be going into as an idea may or may not work. Many times in this network, we've had to step back because people told us, no, we cannot do that, or we cannot do what you want to do until you do for us what we want you to do. And so I think the benchmarks are, do you have a connection and an introduction into that community? Are you really willing to do your own self-exploration about what your biases are? Are you really ready to listen and to go wherever the community is leading you? And so if you're not there, I would suggest this is not the kind of work, this community-based participatory research is not really the work that you want to go into.
And do any of you want to add to that at all, Doug or Fabio? No. No.
No, I mean, I think Monica pretty much said it. I mean, it's really, for us, in particular, working with these communities, one of the things that has been clear from the very get-go, it's always, it's always make sure that you have the right people in the room. A lot of times, sometimes you might have, and in some of the different communities that we work in Brazil, sometimes you have the self-appointed community leaders that they might not really be the community leaders that you want to have in the room. They might not be the folks who actually...
do you mind me asking, how do you get a drug lord onto your...
Yeah, so that was a 90-year-old lady that she came down to, because we had to have a program for physical activity for seniors at the local university. No, she wasn't. She lived up in the slums, and then she came down because she had seen a flyer or something, so she came down for the program. And she was wondering how come she couldn't participate because they didn't have anybody doing that. So she kind of made the introductions for the folks to get in there. And then actually before we could do that, we actually, the team down there, they actually did a number of community types of community types of projects, kind of helping with housing and different things around the community before they actually allowed them to go up. Yep.
Yeah, hi. I'm Greta Massetti from the CDC again. So the question I have is if you could speak a little bit to how the work might vary or what the similarities might be when you're working in relatively diffuse areas, where either rural areas or areas where there are populations that the target populations are spread out versus areas where the population is more concentrated, and how especially that affects your use of resources and the infrastructure that's available. No, I think that it's relevant to all of the speakers, yeah.
Okay, so I can start. And certainly in many of the communities, we definitely have individuals that are spread out. The way we sort of section off the project is county specific. And then we also had a regional staff person. And we basically identified, what might be either a central organization, community-based organization, or location that would draw in most of the individuals. So we have, weekly classes or sometimes twice a month. So we have to identify where that location might be. And oftentimes it's a church or a school system, someplace where people are naturally coming to, and all of that is dictated by our work in that community. So again, by having the staff person who lives in the community, they're very familiar about where people go to congregate, what sort of an easier location to reach. And they also do a lot of home visits and travel around. So part of the challenge with the sustainability of the kinds of programs that we lead are that they are particularly expensive because we have to include travel for people to move around. While we don't pay our volunteers, we do give offset their travel costs to be able to do some of that work. And then physically where we are relative to where the communities are when we need to go and do assessments, we take van loads and we go to where they are. So I think it's very carefully and by knowing and having the community members be a part of our advisory team and part of our paid staff, they help us figure out where to go, and then we try to find resources to get people to where we are.
Well, I'll echo Monica's earlier comments and current comments, certainly in terms of community development and the entire planning process, the investment. No amount of investment is enough, and no amount of investment in planning is lost. But it certainly is an iterative process, and so much of it is built around developing relationships, be it local health, global health, et cetera. And there does seem to be a threshold, so to speak, in terms of reaching rural populations in terms of recruiting from rural areas to a center or taking technologies out to be at the village level or the household level, et cetera.
Hi, nice job. This is Mona Soraya from CDC. I had a question about something that Doug, you spoke about in terms of the high percentage of populations from Latin America that are in the U.S. Thinking about how to bridge the low resource and the low resource areas, as well as countries that have that impact the U.S. And this may speak to how we can, as a U.S. government, invest a little bit more into people, foreign-born populations. Because in TB, for example, when I worked in TB for a year, that was a huge rationale for investing in TB control in the border as well as other areas, high percentage of foreign-borns. So one of the things I wanted to speak to was surveillance systems that really comment on the percentage of gastric cancers in the U.S., for example, that occur among Latin American populations by country of origin, if we can sort of improve our surveillance systems to address that issue.
No, that's a great question, and one that's near and dear to my heart, and probably Kathleen's also. And certainly our immigrant populations from Mexico and Central America are perfect examples. Large overall, that's probably over 50 million individuals plus that are here in the U.S. If we look at surveillance systems, they're not in place yet. But as we move to develop population-based cancer registries in Mexico and in Central America, I think that will be informative. Number two is leveraging the science. I think that certainly for first-generation immigrants, what we learned south of the border has immediate implications for at least the Hispanic Latino populations that we serve up north, and certainly vice versa. So I think those are important points. And then lastly, if one looks at, and this is held up in the most recent data for cancer in Hispanic populations, the core 2 cancers that are increased in Hispanics, while overall the cancer burden is less, are indeed the infectious cancers, so stomach cancer and cervical cancer. So I think, again, focusing a bit with our limited resources, both here and there, can go a long way.
Yeah, I just wanted to mention that I think for cancer registries in the U.S., we don't collect or have high quality data about whether they're U.S. born or not, partially driven by stigma associated with collecting that information, but it may be helpful for other surveillance systems as well. I also wanted to speak to, you had said it would be nice if there were some interventions that would work with other existing interventions, and can you speak a little bit more to that? Like, when somebody's screening for cervical cancer, and this is just a general comment about packaging of interventions in general. For example, for in India, they do breast, oral, and cervical cancer screening together, packaging those. Wondering if you can speak to that and what you're thinking about for Latin America.
I think demonstration projects would be worthwhile, and we'd have to collectively brainstorm about what might work. One idea that came to mind this morning was the idea of mobile units. We, in fact, have done some mobile screening with endoscopy for gastric cancer, and certainly that is a possibility with cervical cancer. Can we do something there that would bring and go out to the villages that would bring both also bring in males also to the conversation built around cancer prevention?
Great. And then one question for Fabio. Fabio, you spoke about the community guide. I'm familiar a little bit with the community guide and some of the interventions we evaluated for cancer screening, and they limited their review to only high-income countries. What can you say about the community guide and its role for low resource or low income settings, and the value of doing either a separate review or combining that review? How applicable are basically the interventions in low resource settings to high income and vice versa?
I think that the question speaks to a larger research scientific issue, right? Because most of the research that continues to be funded and most of the research that continues to be published are research that adheres to the high internal, strong internal validity types of research. And those research, that funding traditionally comes from high-income countries, and the U.S. is one of the leading nations with that. So if we think about how our research and how our science and how knowledge is, from that perspective, is produced and is funded, then we'll understand why most of those types of that's the type of evidence that we're going to find, and if that's the type of evidence that we're going to look. So I think from that perspective, what we can learn from the community guide is that when we look and we only consider internal validity, then those types of research that focus on high intensity, high control, and those kinds of things, those are the ones that are going to pop up. The discussion that we tend to make is that we believe that you need to have a balance between internal validity and external validity. And more of the community guide, and the NCI started doing some of that on the cancer control plan. Now they added the re-aim scoring rubric there, but only for those interventions after 2012, because that's when they added the rubric. So we don't have, they haven't gone back and done the rubric. So that makes it harder. But things like the re-aim framework and all other types of evaluation tools, where we can actually start thinking about we can understand the context of these interventions, that will help us to understand how they might work for low and middle income countries or not. As is right now, for a lot of these, we just don't have the data. Most of the studies coming out from those low and middle income countries, they focus on is epidemiological data. That's the biggest things that they do, cross-sectional data, and that's the types of things so we don't have a whole lot of information as far some of these interventions. Some of these interventions now we're start talking about how do we then take the interventions that have worked on high-income countries, and how do we take those down there, and then how do we adapt them for that culture. The funding is not there. That becomes an issue.
Thank you.
I have a question about messaging and how you go into a community, and I'm going to direct this question to Doug, just because, again, you're dealing with people who largely are asymptomatic at the point that you're intervening, and how do you get that message across to that population, and with an intervention as varied as yours is, that has a pharmacologic component as well as behavioral component, how do you get those messages across?
I guess by iterating. But a lot of that work are done by and with very talented collaborators on the ground. And part of it does have to do with public health campaigns built around cancer and the important cancers in a given region. Certainly in some of the mountainous regions, for instance, in Western Honduras, the message has gotten out in terms of stomach cancer being an important cancer. Individuals sometimes seeking screening, or at least having a low threshold for given programs.
I'm sorry. Go ahead.
Neil Palafox, University of Hawaii. It's a question for Dr. Almeida. One of the jobs we have, I think, in cancer control is explaining risk reduction. And notwithstanding that risk reduction is a hard concept in and of itself, in physical activity, I find that it's probably the hardest to explain. So, even on the recommendations, 30 minutes of moderate, 150 minutes of moderate, whereas you have in cigarette smoking, you can say, if you stop or you go half a pack, or you improve life by this much or these many years, or if hemoglobin A1Cs and diabetes, you avoid these kind of risks. But in physical activity, what is the evidence behind if you do 150 minutes versus 20 minutes versus 75 minutes, and how do you transmit that to, a risk reduction model and explaining it to a community? Because I must say it's hard to understand.
Yeah, no, that's a great question. There's a group that back in 2012, right when we had the Olympic Games over in London, the Lancet came out with a whole issue just devoted to that question, kind of talking about physical inactivity, risk reduction, and in short, some of the things some of the calculations and some of the papers that they had, I kind of talked about. They're able to account the physical inactivity accounted for about 9% of the overall deaths in the world. So it was about 5 point some million deaths. And then they go through this whole risk reduction. And I don't have the paper with me, but basically they are able to account for kind of in a similar way for they do adjusted living years that for every minute of physical activity that you engage at the 150 minutes or more that you save. But I don't have that data with me. But I do have the papers I can send you. But basically the way that there's two things about the physical activity recommendations right now. One is that there's plenty of data kind of suggest the 150 minutes as the recommendation. That's for overall health. And then there's the issue of now there's some new data coming out that to suggest that just sedentary behavior, so the amount of time, and we're talking about during waking hours, the amount of time that you spend sitting or laying has an independent additional risk to your health and to a lot of these. Now they're still coming up with the actual how the exact risk reduction numbers work. But for us, a lot of times, a lot of the messaging that we do is around, there's a lot of data suggesting that, for physical activity, pretty much any physical activity, as it has been suggested, it would be, if you could take physical activity and put it into a pill, would be the wonder drug, right? So because basically it works for every type of disease, every type of a chronic disease that you can imagine, physical activity has a positive impact on it. And it becomes fairly easy for us as we're messaging around just being more active from that perspective and working with populations where a lot of times literacy levels are an issue. If you just talk about that, if you move a little more, if you do things in a more active lifestyle, you're gonna have all of these different types of health benefits. So that's usually how we tend to package that messaging, not as much as the specific, how do you quantify? Now, I can point you to the folks who are the experts in the field, and they will be able to really quantify. They're able to quantify that.
Yeah, I'm going to, and I think that some of the data that you presented on your slides came from the World Cancer Research Fund, and who does continual updates and meta-analyses. So I think you could really find some good statistics there.
And
I am going to wish everybody a really great end of the day, and I know that there is a reception up on the 3rd floor. So please join us on the 3rd floor for, I think there's little nibbles and wine, and Fabio's going to get everybody exercising up there, right?